As you know, autologous stem cell transplantation remains the most effective, one of the most effective way to treat myeloma, and any what we call transplant eligible patient who is fit enough with not too much comorbidities should get at some point an autologous stem cell transplantation. That remains true even though we have outstanding new drugs, new proteasome inhibitors, new IMiDs, and the combinations give indeed excellent results. But still, today, and that has been shown with numerous phase 3 trials, comparing an upfront transplant versus a delayed one, and every time the upfront transplant, autologous stem cell transplantation, was superior, and actually the very last trial was performed by the IFM and in collaboration with the DFCI, the Americans, and this is in press actually, and the patients very briefly got VRD, Velcade, Revlimid, Dex, and upfront transplant versus a delayed one at relapse, and the option of upfront transplant was largely superior to the delayed one. So now, even though we are improving myeloma treatments, relapse is also almost inevitable. We, within the EBMT, the European Society of Blood and Marrow Transplantation, decided to look at the registry and to see what was the role of autologous stem cell transplantation at relapse, and specifically patients who already got 2 autologous stem cell transplantation, and that actually is the case. In the past, we used to do tandem autologous stem cell transplantation, meaning within 3 months time lag, and these people do relapse. And we also have patients who have a first transplant, a first relapse, a second transplant, and then a subsequent relapse, and a third transplant. And the question actually was what is the outcome of these patients? And one of the question was also, is it detrimental? Do you induce myelodysplasia? And is there any benefit to do such third transplant? And what we found is indeed there is a benefit. But before talking about the benefit, we didn't find in both scenarios an increased myelodysplasia or secondary malignancies. So it's feasible. Of course, you have a little bit higher hematological toxicity, but besides that, it's feasible, and we didn't find any increase of TRM, transplant-related mortality. A little bit higher than one, it's about 4%. So, but no major issue in terms of safety. And the most striking result is that, and that's the same in the first transplant, it depends on when the relapse occurs after the second transplant. And now I'm talking only on patients who got a tandem transplant and then had a first relapse. So if the first relapse is long enough and at least 2 or 3 years, then you do really benefit from a third transplant, and with still a substantial long PFS and still a long overall survival. So we defined a kind of threshold that if you do relapse after a tandem, and if I remember, it's at least 2 or 3 years after the tandem, then it's worth doing a third transplant. In the other scenario, it's the same story, if I may say, but of course they relapse much earlier, because this is they already got 2 relapses post 2 transplants, so the relapse occurs much earlier, and the threshold is at least 16 months. I mean, if it's before 16, within 16 months, it's useless. I would not say guidelines, but I would say that if any clinician is considering at some point a third transplant, this is an interesting information and in a way reassuring, meaning that they will not experience too much toxicity. And if the relapse occurs long enough after the second transplant, there is some benefit.